Good day. My name is Joost Wierscha. I'm an infectious disease physician working in Amsterdam in the Amsterdam University Medical Center. So for this presentation, I would like to share with you some insights on the current antibiotic therapy for patients with sepsis. And I will give a short summary of the Survive Sepsis Campaign guidelines on exactly this subject, the use of antibiotics. So this is my disclosure slide. Most importantly, I was also a member of the Survival Sepsis Campaign guideline and heading the group, the infection group of this guideline. Here you see it. It is has been published recently in intensive care medicine and also in critical care medicine. The Survival Sepsis Campaign guideline, the international guidelines for the management of sepsis and septic shock, and it was steered by Laura Evans and Andrew Rhodes. For the Survive Sepsis Campaign infection panel, these were the members. It was a representation of societies from among the world of ER physicians, intensive care physicians, microbiologists, infectious disease physicians, etc. But also extremely important, all the methodologists. And I would like to mention my co-chair, Morten Highlander. So when you take a bigger look and look at how we should treat sepsis, I like this cartoon about sepsis, the latest evidence. Here you see all the different strategies that has been tested in the last decades about which fluids to give, which vasopressors to give, how to feed your patient, to give insulin therapy, yes, no, and how you should do that, etc. But now I would like to focus on the use of antibiotics. Of course, when you look at the literature of sepsis, it can be quite challenging because there are so much differences in what is our definition of sepsis, which patients are included, etc. And I like this quote of one of the godfathers of the sepsis field, John Marshall, who says, "Sepsis is not a diagnosis, it is a phenomenon." And all these challenges when reviewing the sepsis literature include these different patients. So are you treating your patient in a high income setting or more in a lower income setting? Do you have patients with sepsis caused by pneumonia or sepsis caused by urinary tract infection? Which definition is used for sepsis? Which other interventions are used? And of course, for all these large, certainly these trials, which outcome measurements are used? Is it mortality, short-term, long-term? Is it length of hospital stay, etc.? So the Surviving Sepsis Campaign guideline uses the GRADE methodology. So what is key here to ask yourself the right questions, and we do that according to the PICO formula. So what's the patient intervention comparison and the outcome? So if the PICO questions are formulated, the literature is searched, and then the evidence is graded according to the level of evidence. Then the panel comes together and formulate recommendations based on the certainty of the evidence, benefits, the harm-benefits balance, the values, preferences, resources, cost, and of course also the feasibility. Then the GRADE methodology rates the evidence, and finally you have the recommendations phrased as recommend using, we suggest using, or we recommend against using, or we suggest against using. These were the most important PICO questions addressed for the Survive Sepsis Campaign guideline on the infection section, the diagnosis of sepsis, the timing of antimicrobials, when to start your antibiotics, when to de-escalate, for how long should you give your antibiotics, antimicrobial coverage, and of course, source control. Important outcome measurements were the following. So what is the specific intervention? What does it mean for your patient for the short, long-term mortality, ICU length of stay, hospital length of stay, readmission, or hospital-free days? So to start, the diagnosis of infection. So it is important to realize that it's quite be quite difficult, can be quite challenging to accurately diagnose sepsis. So this is an example of a study published in Critical Care in which they used a large cohort of patients with sepsis and then after inclusion went back to look at the original diagnosis. Was it correct? And they conclude that a third or more of patients initially diagnosed with sepsis turn out to have a non-infectious condition. So the bottom line is for adults with suspected sepsis but unconfirmed infection, one should continuously re-evaluate and search for alternative diagnosis and discontinue empiric antimicrobials if alternative cause of illness is demonstrated or strongly suspected. So in patients suspected septic shock, should we administer antibiotics within 1 hour or later, 3 hours from recognition? And in patients who are less severe ill but still have sepsis, so patients with sepsis but no shock, should we administer antibiotics within 1 hour compared with 3 hours? This was one of the key questions summarized as asking yourself, how, when I have a patient with suspected sepsis, how fast should I administer my antibiotics? These were the PICO questions. And it has been an often debated question. So just to give some side information, I like this editorial written by another sepsis guru, Mervyn Singer, in the Blue Journal. I like this title, Antibiotic for Sepsis. Does each hour really count, or is it just incestuous amplification? And he even gives an explanation of these words with it. But his quote is, each hour's delay in initiating antibiotics costs lives has become a doctrine that has attained quasi-religious status. And like most quasi-religions, this is found more on faith and hope than hard fact. Well, within the Surviving Sepsis Campaign guideline, we put all the evidence on a pile, and there has been a lot of papers published on this subject. When you look at time to antibiotics, in sepsis, more than 5,000 PubMed hits appeared. One of the most cited ones is the one from Kumar, published in 2006 in Critical Care, about the duration of hypotension before initiation of effective antimicrobial therapy, and that relinked with outcome. Important, there's only one RCT in this field, published by Alam in Lancet Infectious Diseases, and it was about pre-hospital antibiotics in the ambulance already for sepsis, a multi-center open-label randomized trial, with only one RCT. A more recent New England paper from the Seymour group also looked at this subject with a large cohort of patients. And I really like this review of the Jerry Calandra group if you are interested to really get a summary only on this subject. So here you see this forest plot on the outcome of the rapid administration of antibiotics in these patients. And the bottom line is in the most sick patients with septic shock, antimicrobial should be administered immediately, ideally within 1 hour of recognition. The data for sepsis, so sepsis without shock, is less clear. Bottom line here is that a time-limited course of rapid investigation is important. So is it really sepsis or not? It's really important to really take into account, is the diagnosis proper, and prevent yourself from early closure and treat everyone for sepsis if perhaps it is not sepsis. So if concern, you have a little bit more time. If concern for infection persists, administer antibiotics within 3 hours from the time when sepsis was recognized. So this has been a change from the previous guideline version. So here you see the same, it's more a summary about the timing of antibiotics. So on the left side is if shock is present and you have sepsis or high suspicion of sepsis, well, antibiotics should be given immediately and ideally within 1 hour of recognition. If shock is absent and sepsis is possible, then it is important to have this rapid assessment of infectious versus non-infectious cause of acute illness, and you have a little bit more time, but still it is recommended to administer antibiotics within 3 hours if concerns for infection persist. Different subject. What about procalcitonin? Can we use it to diagnose sepsis? Well, the recommendation is for adults with suspected sepsis or septic shock. The guidelines suggest against the use of procalcitonin plus clinical care to decide when to start antimicrobials as compared to clinical evaluation alone. So it is not recommended to use procalcitonin to diagnose sepsis, but perhaps you could use procalcitonin to decide when to discontinue antimicrobials when you have already started antibiotics. Here you see again a summary of the available evidence from the use of procalcitonin, and not real big differences were seen. And the nice thing is that for adults with an initial diagnosis of sepsis or septic shock and adequate source control, when the optimal duration of therapy is unclear, one could use procalcitonin to decide when to discontinue antimicrobials. So there seems to be a role for procalcitonin. However, then you have to ask yourself, how often is the optimal duration of therapy really unclear? And that brings us to the next question. In adults with sepsis or septic shock, should one use shorter or longer duration of antimicrobial therapy? Here you see a summary of available evidence on RCTs that address this question of duration of empiric antimicrobial therapy, short versus longer duration of therapy. Here you see patients with pneumonia, patients with bacteremia, intra-abdominal infection, and urinary tract infections. And actually in all these studies, no differences in outcomes were seen in patients treated with a longer versus a short duration of antibiotics. So here, the bottom line is for adults with an initial diagnosis of sepsis or septic shock and adequate source control, a shorter course of antibiotics can be suggested. And it has a lot of advantages. It's less costly, it's convenient, and fewer undesirable effects. And of course, it is very important to underscore here the antibiotic stewardship principles, the importance of daily assessment for de-escalation of antimicrobials. And once again, if the duration of antibiotics is not really clear, procalcitonin can have a role there, but in most cases, like pneumonia, sepsis caused by pneumonia, sepsis caused by urinary tract infection, etc., it is already quite well established for how long you should give antibiotics. The next question about antimicrobial coverage, which antibiotics to use, and that of course is really a question that depends on which part in the world you are practicing, and also what's the backline resistance and what are the available antibiotics. A lot of studies have addressed which combination would be the best. So should you give beta-lactam monotherapy or beta-lactam with aminoglycosides? Or should you give a meropenem, carbapenem with quinolone, yes or no? So this systematic review by Chauvel is really a key paper in the field, which really addressed this in a systematic fashion. Here you see again the recommendation. So for adults with sepsis or septic shock and a high risk for multi-drug-resistant organisms, it's preferable to use 2 antimicrobials with gram-negative cover for empiric treatment over 1 gram-negative agent. For adults with sepsis or septic shock and a low risk for multi-drug-resistant organisms, one can suggest against using 2 gram-negative agents for empiric treatment as compared to 1 gram-negative agent. So I think that makes perfect sense. The key thing, it's really important to know in the setting you're practicing, what is the baseline resistance? So what are the most commonly diagnosed infections, pathogens, and what is their resistance pattern? The last bullet point, important, also change from the previous guideline for adults with sepsis or septic shock, double gram-negative coverage once the cause of pathogen and susceptibilities are known is not indicated. What about empiric antifungal therapy? So the question here was, in patients with sepsis or septic shock at risk for fungal infection, should we include empiric antifungal therapy? Well, quite a number of studies have addressed this question. Not a real overall significant effect that would favor the empiric use of antifungals in all these patients. But of course, it all depends on the patient you are seeing, which risk factors are present. So the decision to start empirical antifungal therapy depends on the type and number of risk factors, along again with the local epidemiology of fungal infections in your hospital setting. So here you see this table. Also, it is from the Survival Sepsis Campaign guideline about all these risk factors for Candida, for endemic yeast, and also for mold infections. Lastly, what about source control? So for adults with sepsis or septic shock, it's important to rapidly identify or exclude a specific anatomical diagnosis of infection that required emergent source control and implement any required source control intervention as soon as medically and logistically practical. So no specific time slot, just as soon as medical, logistically practical, the pus, if present, should be evacuated. For adults with sepsis or septic shock, it's important to promptly remove intervascular access devices that are possible source of sepsis or septic shock after all vascular access has been established. Well, it has not changed, and it's already common practice. So this is the last slide of this presentation. A summary of the use of antibiotics from the Survival Sepsis Campaign guideline. So this infection section is about the diagnosis of sepsis, the timing of antimicrobials. We discussed when to start, to de-escalate, and duration of antibiotics in patients with sepsis, the antimicrobial coverage, and about source control. So I would like to once again thank my colleagues on this committee, and thank you very much for watching.